Hello, hello. Welcome back, everyone. Welcome back to the CT Blueprint course. This is lesson 5. So lesson 5 is going to talk about CT image acquisition and parameters. So this is kind of like the nitty-gritty of this course. So I'm going to give you lots of information here. So remember, this is, like a crash course, and in future lessons, I will dive into more of some of these principles. Now, scan parameters. So in CT, if you're familiar or you're not, or you have a sense, CT utilizes two types of scanning methods. So the two types of scanning methods that we have is axial. So that's your basic step and shoot, which is typically used for head imaging because of the image quality, and it produces less noise, but it does increase the radiation dose to the patient. So what I mean by step and shoot is if you have like systems like a 64, or sometimes the 256 does have an axial mode where it sets up, you set up your entire exam and it goes from a section, it'll image, then moves the table to the next section, image, next section, image, next section, image. So that is what we call a step and shoot. Lots of times these are used for biopsies because radiologists need a few pictures and they need to know exactly where their needle is or the drainage tube that they put in. So that's why we call it a step and shoot, because it takes a section of images and then the table moves to the next section. So this is typically used for head imaging because you have less noise, the rotation time is not as fast, and it gives you better image quality. But the radiation dose, of course, is going to increase because of that. Now, we also have helical mode. So this is faster imaging, okay? This is used for body, extremities, neck, like CTAs of the head, any CTA imaging, like certain head protocols, like a stealth, like facial bones, things like that. However, with helical scanning, you get higher noise, but you get less dose. So that's why we have all the when it goes through the back filtration system and all the algorithms to clean up all that noise before the image pops up on our screen. Okay, so those are the two scan parameters that we typically have in CT. Now, you might hear some common scan terms. If you're kind of newish to CT, you might not have heard it, but some, physicians that have been in medicine for a very, very long time, you might hear a term called spiral scan. There are some physicians that still use this term to this day. So this is a pretty old term, and it has the same meaning as a helical scan. When I started CT 22 years ago, there used to be physicians that used to write in their paper orders, spiral CT to rule out PE. So basically what they're meaning is that they want just a helical CT, to rule out PE, okay? So many, many moons ago, the reason why it was called a spiral scan is because you had to switch it to that mode on certain CT scanners, from what I understand. But the very first CT scanner that I ever worked on was a Picker 6000. Very, very old machine. That company got bought out by Philips, so they own that name. So, and that one actually had the ability to do helical scanning, but you had to kind of toggle. So that's why they would write in their paper orders spiral scanning. So you might hear this term, you might not. There are some physicians that still use this. Now, your CT images and your views. So CT images can be constructed in various views. So it's referencing the anatomical position of the body. Okay. So, you have your basic anatomical position, you have your coronal, your sagittal, and then we do some 3D post reconstructions like a MIP and a 3D VR. So a volume rendering. And then oblique views, of course, we can, you use for like a CTA of the chest and temporal bones. Now, every facility is different as far as their protocols. I know at the facility I work at, it's a level 1 trauma center. We have to do oblique views on a CTPE. So we have to do a right oblique and a left oblique, which that's the first hospital that I've ever had to do that. I have heard that other hospitals do that. Now with temporal bones, I've done a video on TikTok as far as that, if you follow me on TikTok, where I describe a protocol for temporal bones where they do a Stenver's view and a postural view. So those are obliques to be parallel and perpendicular to the ossicles, okay? So you can see the inner part of the ear very well. So those are the scanning type, the common CT image views So we reference everything to anatomical position, which we learn early on in x-ray school. Now, here is an image. This is a typical axial view. So when you scan a patient, the picture on the right is exactly what you'll see. So it's in an axial plane. Remember, anatomical position. So it divides the body into upper and lower parts. So you go from superior to inferior. So from the very top of the lungs all the way to the adrenal glands, for example, for a chest CT. So this is the common view that we see on a CT image all the time. Now, we also have something called the coronal view. This is a coronal view on the right. So this divides the body into anterior and posterior parts. So if you scroll, you'll see it, from anterior all the way to the back. So this is typically post-processed after imaging the patient. So this is the work that we do after we're done scanning. Now, you also have a sagittal view. So this is a sagittal view of the head. Okay, so the sagittal plane divides the body into right and left parts. So you go from the right to the left. Okay, so this is also post-process after we image the patient. So these are the views on just about every part of the body. That's, standard procedure nowadays to go ahead and do after we're done scanning the patient. Now, when it comes to CT angiography or any CTA exams, or sometimes we do it on the regular chest CTs. So you have your MIP image. This is your maximum intensity projection. So this is also done after we image the patient, where you see the vessels really nice. You kind of bring the vessels to the surface, as what one radiologist told me. So where they see the vessels really nice and they can make a really good diagnosis. So like I said, this is used for CTA imaging, or it can be imaging of the chest. There's a facility I worked at where every chest CT, it didn't matter if it was a PE study or without, it didn't matter. We had to do a MIP image of the chest, and they only liked a coronal view, not a sagittal view for some reason. I'm not quite sure why, but sagittal or a coronal view was perfect for them. So I always encourage everybody, make sure you check your protocol books. Everything that I give you in any of these lessons are just generalized protocols, because I've taken what I've learned throughout the years at every facility and just kind of made just a general protocol that almost matches just about everywhere that everybody works at. Now, we also have our VR, so our volume rendering, or this is a 3D view. So here on the right, okay? So this is also done after we image the patient. This is a post-processing step. Usually we do a 3D. It's used in trauma cases, extremities, and heads. Anything that they're suspicious of fracture on, we go ahead and do a 3D image or a volume rendering. Now, your image parameters. Certain parameters are used to acquire a CT image. Okay, so I'm going to give you a good perspective on some of the techniques displayed on CT images. Now, the very most important one, of course, it's named after one of the founders of CT, is Hounsfield units. Okay, so Hounsfield units is a display of different densities in tissues. So Hounsfield units is what we measure when we do QA every single day, and making sure that all of our numbers and our densities to our phantom match up correctly, are within the standard deviation. And then we have our window width. So these are, the different attenuations that you see on your image, okay? So this is also called the center. So this is the midpoint range of the Hounsfield units. So this is going to give you your brightness of your image, okay? Then you have your window level. So your window level is your Hounsfield units as shades of gray. So this is the contrast of your image, okay? So if you kind of see like on a picture of an image, you'll see, your window width, your window level, and you have different window widths and window levels for every type of exam, whether it's bone, lung, soft tissue, whatever the case is, you have different ones for that. Now, here's going to be some very important principles that I'm going to go ahead and go over, okay? So scan field of view, or your SFOV. Now, your scan field of view determines the area along the gantry where raw data is acquired, okay? So basically, to explain this is how much anatomy is going to be imaged. This is how much anatomy you're going to scan. Now, I'm going to stress this very importantly. Isocentering and patient positioning are very important when it comes to your scan field of view, because critical anatomy should not be outside of that scan field of view. So if you center properly, Everything that you're supposed to image, what they're looking for, should be within that scan field of view. Now, I know that there's going to be patients that are larger, they're morbidly obese, and we have to try to include all the anatomy that we can. So I always tell everybody, use your best judgment, use your table straps. If you got to use some tape, make it happen, okay, without harming the patient, because that's what we're there for. Quick story, there was a patient that they were looking for this hernia, and every single time he got a scan, that part that they needed was always out of the scan field of view. So I said, okay, we're going to make this happen. So I told the patient exactly what we were going to do. I instructed him on how we were going to do it. I said, sir, I'm very sorry, but we really need to get this so they can treat you. I took the table straps. What I did is I wrapped them in a sheet. My partner and I, we taped him, we taped his belly, and we just tightened those straps. I know it sounds horrible. However, because we did all those measures, they found out exactly where the hernia was. They took the patient straight to the OR, and he got fixed. Within a week, he was good, and he got out of the hospital. So I always stress, do the best you can, making sure that you get everything in that scan field of view, and talk to your patients, let them know why, so they don't have to come back for more imaging, okay? Now, your display field of view. This is different from your scan field of view. So your displayed field of view, or your DFOV, is the area and section of acquired raw data that's used to create an image. So your display field of view can be less or equal to your scan field of view, but it can't be greater than that. It cannot. Like, your display field of view cannot be more than your scan field of view. Just because you think, oh, well, my display field of view is going to give me more than what I scanned. Not going to happen. Okay. So make sure that ISO centering and patient positioning, and making sure you include everything in your scan field of view, is going to give you the correct display field of view. Now, what I want you to remember, because some texts do confuse this, is that your DFOV is different from your scan field of view. They have separate functions, so very important to know. Now, you have your slice thickness, okay? So here's kind of a picture of your slice thickness. So this is on a GE64, okay? So you can pretty much find your slice thickness on every scanner, whether it's Siemens, Philips, Toshiba. I know it's called Canon now. Calm down, guys. It's fine. I'm an old school tech. So the resolution of the scan is determined by the detector width. Okay, so this is at a 5 mm thickness. Okay, so here's a perfect example. So your protocol is set to scan a patient at 5 mm thickness. So you would receive a 5 mm image data set. So it's 5 by 5. So thickness at 5, interval at 5. So that means that they're contiguous. So they're stacked, together. Okay. So dependent on the anatomy being imaged, your slice thickness can range from like a 0.3 to a 5 mm. The only time that we would use like 10 is when we're doing high resolution scanning. So different systems out there have different slice thickness and different incrementations. Like GE does like 2.5, 1.25. I know like Philips, you can do the same kind of incrementation. Usually it's like 2 or 3 mm or 1 mm, whatever the case is. So, but this is basically a general range. But usually most of the CT systems out there are pretty much identical. Now, your raw data. These are the binary numbers that are collected by the X-ray signals from the detector that represents your digital image. Okay, so this is the data that's stored on your local drive. And if you need to go back and access it, you can reconstruct additional images. So you can create like another sagittal coronal, another axial data set, like a little bit thinner to make a 3D reconstruction. Whatever it is you need, your raw data is there so you can do it. Now, typically, and I know this changes from machine to machine, facility to facility, raw data can stay on the CT system for up to 2 weeks, and then it's set to automatically delete. Now, I know at our facility, we have high capacity use. We have 5 CT scanners, okay, that are all fully functional 24/7, okay? And usually that raw data doesn't stay on there for no more than a week. It's because of the high volume and just the high capacity of scanning that we're doing. So typically that's kind of general, up to 2 weeks. Your facility might be less because it depends on capacity and high use. Now, your image data, which is different from your raw data, this is also called reconstructed data. So this is pixel data collected from the scan data, and it's used to display your images. So once it's all reconstructed, that's what you get on your image. Your raw data and your image data, they may sound familiar, however, their functions are completely different and can be confused. Some texts that I've trained confuse this. So remember, your raw data stays on your system, okay? And you can access it and do another set of reconstructions if need be. And then it is set to auto delete after a week, 2 weeks, whatever it is, where your image data, all the data that's stored like on your patient list is deleted by the user. But once you delete it, you can't get it back. You can't recover it. So let's say if your local drive is full and you're trying to do some reconstructions and it tells you, the database is full, delete images. That's exactly your image data that you're deleting. It's not the raw data, it's the image data on your patient list so that you can create more recon so it's stored there. Now, in CT, we typically get artifacts. So like motion, beam hardening, streak artifacts, things like that. And usually because of motion, it's because of patient movement, patient didn't understand instructions, patients that are combative, patients that are not with it. Beam hardening because of, artifacts within the body, like pacemakers or, stimulators. If the patient's had any heart surgery, LVADs, that can cause, any beam hardening or streak artifacts. Typically, beam hardening where we see it is in the head because of the Petrus ridges. So that's why we angle 15 to 20 degrees on head CTs if your gantry is able to angle to minimize that streak artifact, okay, and that beam hardening. Or, anything that shouldn't be within the, body being imaged will cause beam hardening because it takes more x-rays to get through the body. Now, patient education on movement during an exam, angling for heads, what I just explained, removing any metal objects that can be removed can reduce this, okay? Instructing your patient to make sure that they hold still for their CT and, not talk and just, minimize the movement as best as we can. Okay, so that is the end of lesson 5, guys. I know I threw a lot of information there. So hopefully this was insightful. I'm going to give you more information as we go through these lessons in this course. So make sure you all are taking notes. That's very important. In lesson 6, we are going to talk about contrast media and techniques. So I'm just going to give you kind of the basics of contrast media, just so you understand just the principles of it, okay? So thank you for joining me in this lesson, and I will see you in lesson 6.